limitations of this particular technique. Now, I have a very pleasant association with CCOT. I got a Korean CCOT award in the first very year of my practice. This was in Hong Kong. Now, coming back to the topic. Now, this is a very obese lady. She had severe L4 root pain. It was phenomenal because she had this extra foraminal disc bulge. Out of all the kinds of disc herniations, is the most painful because this sits on the neck of the root, that is the ganglion, and it irritates a lot. And in fact, she was on Fortwin. And when she requested us to operate, take the pain away, it would have been phenomenally troublesome if you had done an open exposure going through the obese lady's back. So this was through the tube. This was a 9. The length of the tube was 9 centimeters down, and within 15 minutes, without any bony work, we could pull this disc out from this lady's extraforaminal zone, and that is where the beauty of this MIS can be appreciated. So these are the conventional workhorses which we are used to. The Cobbs, the self-retaining retractors. It looks very, very ancient when our own colleagues in different arenas are doing high technology work with very good results in terms of pain relief, recovery, and cosmesis. So this is something which has captured our imagination for a few years, and this makes us slightly, in a competitive mode with our colleagues. So these are my workhorses. About 70 to 80% of my workload is through the tubes. So we do discectomies, decompressions, we do interbody fusions, everything with these tubes, small tumor removals, etc. So these come in various lengths and various diameters from 16 to 22. That's what we use. Expandable, non-expandable. So most of the work that we do is focal. So there is a disc herniation at a certain point. We need to just go there and remove it. They are all targeted surgeries for which just to get onto the target, we do an extensive exposure and add morbidity to this to the patient. So this is how it works. This is the initial part of my practice. This is L4-5 disc herniation. This is armamentarium. So this is the guide wire which bisects the disc space of interest, which is checked on the C-arm, and then go a series of dilators of increasing diameters. So a straightforward discectomy is done using a 16 mm diameter. So these vary in length from 4 to 9. Depending upon the depth of the patient's back. So there goes the final port, which gets connected to this flexible arm, which is attached to the railing of the table. So the flexible arm helps in tilting the tube in whichever angle you want to. So that is the cranial end, this is the caudal end. So this is the burr. So once the laminotomy is done with the burr, see the flavum there. So that is the flavum, that is the fat. You can see the dural sac. So once the tube goes in, the surgery is similar to a microdiscectomy. So that is the root. That is the shoulder of the root, that is the lateral recess that I am decompressing. So that's the nerve root retractor. So you see this glistening disc. You need bayoneted instruments here. That is the annulotomy. And there comes the disc out. This is one of the real basic surgeries that we do with the tube. So those are the fragments. This nerve hook is a very, very vital instrument when you do any kind of discectomy. It brings out those fragments which are tucked in the corners, hidden in the axilla, shoulder, opposite side, superiorly, inferiorly. So as you see, so that is the foramen which is free. The local depomedrol that I use, gel foam for hemostasis. The tube comes out, there's hardly any dead space. And this is the length of the incision. The patient goes home the next day. Now, this is what we published 3 years back, and we have close to about 400 cases now. So, the advantages are the beauty, hardly any tissue inflammation, hardly any nerve root retraction because the tube doesn't allow you to retract beyond a certain extent. So be it a superiorly migrated disc where the tube is parked. So the beauty is that you can park the tube wherever you want to target that particular pathology. So this is superiorly migrated. So I dock it on the lamina and just make a hole there. So you see, and because of magnification and illumination provided by the microscope, you can really delineate all the structures very well because everything looks the same. Everything is white but different shades. So that's the route that is free. Now again, inferiorly migrated disc. You see, you don't have to go to the disc and then trace it down. So you angulate your tube inferior right from the beginning. And all that you need to do is excise some phlegm and you're on the disc. So there comes the disc. Now, as I said, when it is just underneath the laminas, far away from the native disc, whether superiorly or inferiorly migrated, we make a hole in the lamina. And through the hole, we remove the disc. So this is the hole, and using a nerve hook, we pull the disc fragment out. And not only did this paper get an award in Mysicon last year, it's also accepted for publication in Indian Journal of Orthopedics. So this patient was initially planned for a TLIF procedure. She had discitis, severe back pain, severe leg pain. She was very unfit for a big surgery. She was quite obese. So what we did was just remove out the tissue, closed it, put her on the antibiotics she was sensitive to, and she made a remarkable recovery. Recurrent disc herniations. This was the length of the previous incision. So she had a disc herniation at L4-5, this patient, So 10 years later, he had a disc which dropped down at the lower level. So usually you go for a L4-5 disc, you do a L4 laminotomy. Here we made a hole through this just on top of L5 lamina, and there we were in 15-20 minutes. We avoided the fibrous tissue that was left behind in the previous surgery. So this is the length of our surgery. Again, if you have two levels involved, just like here, L4-5, L5-S1, a small little incision, you can imagine the length of the incision for a L4-5, L5-S1 pathology. It would be quite a long incision, especially in an elderly, especially in an obese patient. So with one incision, you can circumvent and do a two-level decompression. Again, recurrent disc herniations, high lumbar disc herniation, it's a technical issue because the facet joints are sagittal and small. So we use the 16 mm tubes and make a very tiny hole through which we pull these discs out. Be it a very large disc fragment such as this. The beauty is whether it is obese or a thin patient, Laurel or a Hardy, the size of the incision is the same, which varies when you do a microdiscectomy. So obese patients have their own issues with regards to wound healing. Here you're not at all bothered when you do procedures on these patients. So these are the kind of obese patients who are the biggest beneficiaries of this particular procedure. So, you can see this patient, I didn't ask him, but he got a postoperative MRI done. So there are issues initially in your practice. And slowly, once you get confidence, you keep extending your incision indications. Now here, tube is very forgiving. So the patient had a left-sided disc herniation. We went on the right side by mistake. The tube was put on the right side. So I didn't want to go on the opposite side. What happens is you do opposite side decompression from the same side and pull the disc out. This is not to be repeated, but in terms of forgiveness, with the tube you can do that. You can go to the opposite side, underneath the lamina on the opposite side, and remove the disc out. Again, tubes are forgiving in terms of dural tears, because there's hardly any dead space there. As soon as you remove the tube, the dead space is obliterated by the soft tissues that fall in place. We hardly get tensed when there is a dural tear in a patient who's undergone a minimal access surgery compared to a patient who has undergone an open spine surgery. This is the beauty of minimal access. Again, doing a wrong level surgery is impossible if you're doing it sensibly, because till the till the final tube goes in and gets locked and bolted in that particular position, you're not going to proceed with your surgery, and it's not going to move. It's quite rock steady when it's on. So all throughout the steps, you're checking your level. So the nightmare of wrong level surgery is almost impossible with minimal access surgery. Again, patients with poor skin indication, these patients can have wound healing problems, but with a small incision, it's less bothersome. Again, infection, we had 0% infection in patients who underwent minimal access decompressions and discectomies, because the exposure of pathogens is very less compared to a open surgery. Again, this is not a very easy technique. There is a long learning curve. This is a patient who underwent 6 types of minimal access surgeries, and the disc was not touched. So by the time he came to us, we had to do a TLIF in him. So there is a learning curve here. Now this is something which I wanted to highlight today, which we just published in Spine. Now this is a patient who has right-sided leg pain. He has a positive SLR. He gets pain on sitting. He gets relief with sitting, with lying down. So obviously this patient will need a discectomy. A similar looking MRI, but the patient has absolutely diagonally opposite symptoms. Patient gets pain on walking and standing, has complete relief with sitting. So this guy patiently has a claudication pain, and his SLR is totally negative. So we did not do a discectomy here. We just did a decompression, and his VAS improved from 8 to 10. He can walk comfortably now. So without touching the disc, we just did a lateral recess decompression here. A similar patient, a pediatrician, he just came for his 3rd follow-up. So this guy has a huge disc here. You can see here. It's a large disc. It's a calcified disc. Now all that he had was a left-sided leg pain, claudicant. He had free SLR. He used to sit after every 5 minutes of walking during his rounds. So we did not touch the parent disc at all. On intraoperatively, it was hard and calcified. We just did a lateral recess decompression. Absolute pain relief. He is comfortable now, very much into practice. Another patient, similar picture. So this looks a very big fragment on the MRI, but this is a calcified disc. So all that we did was a lateral recess decompression. So basically, don't treat the MRI, don't treat the patient's clinical symptoms, by his clinical symptoms. I'll rush through these details. So basically, the crux of the matter is that, these discs occupied a large volume of the canal, sometimes extending to almost 2/3 of the canal, but these patients had no discogenic pain. These patients had pain only on walking or standing, and with complete relief on sitting. So, and compared to a regular disc herniation patient, these patients had a longer protracted symptoms, and they all did well. So why not touch the disc? Because these are not those disc herniations per se, wherein initially you have the chemical reaction happening which causes nerve root tension and pain. These are patients where the discs, that segment has reached the stabilization phase of Kirkaldy. Instability, stability, degeneration, instability, and stability. So here the facets are hard and burnt out. The disc is hard. It doesn't cause any mechanical compression per se anteriorly to the root. So these degenerative changes cause aggravate the lateral recess stenosis. All that these patients need is lateral recess decompression. And again, believe me, removing these hard discs is not very easy. You use an osteotome, use the burr, and you can cause neurological injuries. Otherwise, you'll have to end up doing a complete facetectomy and fuse that particular level, which is not necessary because the disc itself provides intrinsic stability to that particular segment. Again, discectomy has its own issues, recurrent herniation, back pain, instability, etc. So why touch the disc in these cases? So this particular entity, we ran through the literature, has not been discussed completely. Most of the journals and textbooks are missing in this particular entity. So that is where we are filling in the gap. So this got published last month. So nature of radicular pain is important, whether to know whether discectomy is required or not. Standalone lateral recess decompression without discectomy is effective in majority of patients with claudicant radicular pain and lumbar disc herniations. Exception is a sequestrated disc herniation, which you see on surprise when you're operating, which happened in 3 to 4 of our cases. So, and the ability to do it with minimal access makes it more focused and targeted. So I hope you have a better understanding of how minimal access discectomy is done. The aim is to re-establish normal anatomy and physiology, and the surgical goals are achieved with less iatrogenic trauma, less pain, less complications, and early reintegration for the patient to get on to his job. And as you see, it's a very versatile approach, versatile procedure, which was probably highlighted by Dr. Vishal Pishatri also in his talk. Thank you very much.
Thank you, Arvind. I think that was quite excellent. And let's move on, because now we know that there's a huge spectrum for minimal access surgery now. So we're going to understand the role of computer navigation here and the benefits and the advantages of computer navigation.